Institute de la Universidad de California de Los Ángeles. Ella es decana asociada de la Escuela de Medicina David Geffen en la Universidad de California, Los Ángeles. Hizo su pregrado en la Universidad de Stanford y lo culminó en la Universidad de Harvard, donde también hizo su doctorado. Estudió oftalmología y neurooftalmología en la Universidad de California de Los Ángeles. La doctora tiene más de 100 publicaciones entre journals, libros, capítulos y revisiones. También pertenece al editorial board de Ophthalmology Retinal, Journal of Neuroophthalmology y Journal of Ocular Immunology and Inflammation. Ha ocupado posiciones de liderazgo en organizaciones profesionales y estatales nacionales. También ha sido presidente del Council of de la Academia Americana de Oftalmología. Y la doctora es decana asociada para la inclusión de la equidad y diversidad. Ha desarrollado programas para el liderazgo de la mujer. La Escuela de Medicina David Geffen está asociada para la investigación de la visión y la oftalmología. Su mayor pasión es ayudar a las personas a alcanzar su máximo potencial. I think this is very beautiful, doctor. Thank you for being here.
Thank you so very much for such a kind introduction, really kind. And I am so apologetic that I can't deliver the talk in Spanish.
No, okay. But people is going to talk, they're going to interview you, they can do the question in English or in Spanish, I can help you.
Right, I know. I wish I were bilingual. I'm going to share my screen, and I want to make this a bit of a conversation because there are so many very intelligent experts that are on this call right now. So I'll share the screen.
Okay, you can share the screen.
Yeah. And let me know. See my slides?
Yes, you can put. You can
Perfect.
put in.
Is that good?
Okay. Perfect.
So I want to thank everyone for being here. A lot of times we get a patient and they have optic atrophy, and that might be the diagnosis that someone is sent with, and that has a long list of possible etiologies. And so the question is, when we see optic atrophy, how do we approach the patient? What do we do next? And I have no financial disclosures relative to this. There was an internet discussion about this about a year ago on the NanosNet, and when I looked at that, I was really so interested because people had all sorts of different ideas, and we know, and I think I'll quote this later, that there are some publications that tell us that neuroimaging can identify a structural abnormality or an inflammatory abnormality in about a quarter of, around 20%, a fifth of patients. There are laboratories that many people do, and each person seems to have their own, preferred cocktail of laboratories to get. Then there were some people that commented about different vitamins, NMO, Wegener, sarcoid. Do we sequence them looking for dominant optic atrophy or Leber's hereditary optic neuropathy? Do we get inflammatory markers? Do we screen for metals and toxins? How about alcohol use or other deficiencies? Do we look for systemic inflammatory diseases, infectious diseases that can lead to optic neuropathy, optic atrophy? And beyond neuroimaging, what else do we do? Do we do a spinal tap? What sort of paraneoplastic markers do we look for? And so one person said, well, they just give them this whole list and have them ask if they've had any exposure. And I don't have any problems with any of these answers, except from a practical standpoint. To me, that doesn't work. Because if you have a patient look at a list like this for any potential drug exposures that have potentially been associated with optic neuropathy, we know a few of them much more so than others, I think that what you'll get from the patient is sort of the hands thrown up because it's too much. And so what I really like to advocate for with our trainees is to do what we do best, what we've been trained to do from our first day in medical school. We talk to the patient. We need to get an appropriate history. We need to find out their family history, what medications they use, what sort of work do they do. That will give you a better sense of potentially toxic exposures. What's their prior medical history? And then we evaluate them. You know, what makes sense to test? That's really what's important is what makes sense to test with these patients. And so there was this nice study done by Andy Lee, who's an outstanding speaker, Mike Wall, Randy Carden, Carl Golnick, just amazing colleagues in neuroophthalmology. And this was done a while ago, but they had about 100 patients, adult patients that had isolated optic atrophy. They did neuroimaging, and they said, well, for these 100 patients, what illuminated an underlying etiology for the optic neuropathy, optic atrophy? And about 20% had compressive lesions. So when I first asked, you know, what do you do for everybody? I would say we do want to get neuroimaging for everybody if we can. What they found in their series was that there were few individuals that had syphilis, vitamin B12 deficiency, folate deficiency, vasculitis, sarcoidosis, or heavy metal toxicity. But even though there was low yield in that patient population, I will tell you that over the course of my career, I've seen patients with each of these as a cause of optic atrophy. So just because it's low yield in large, studies of patients doesn't mean that it's no yield. And so the appropriate clinical setting or history really needs to dictate your evaluation. And obviously you always want to follow the patient because you want to know, is this something that's static and unchanging, or is this something getting worse? And if it's getting worse, is there any way that we can intervene and allow them to recover some vision? And so whenever I see a patient, I think of these are my golden rules. Number one, what if I miss it today can lead to either permanent morbidity or mortality? Because those issues, I'm going to want to figure out, what testing do I need to do today? And what results do I need to look at today? What's your differential diagnosis? And then how do you proceed with the evaluation and management in a structured way? What's potentially treatable? What's the urgency of the evaluation? Do you have hours? Do you have days? Or do you have weeks? And so what I want to do today is just look at a number of cases and talk through them. And please feel free to ask questions. Comment, let me know what your thoughts are. And Emily can be the conduit because I can't see necessarily whose hand is up or who's asking a question. So really, when I think of optic atrophy, I think, well, what's that broad differential diagnosis of optic atrophy? Well, did someone look and see a funny looking nerve that was not actual atrophy, but was optic hypoplasia? Was it an abnormal disc from the time they were born? Is there something structural there? Idiopathic to me means, I or the world hasn't been smart enough to figure it out. And for all of us that are on this call, we know it's it's really unsatisfying as a diagnosis. Could it be hereditary, in particular Leber's hereditary optic neuropathy, dominant optic atrophy, syndromic, hereditary genetic diseases that are commonly associated with optic atrophy and nobody ever looked? Is it toxic or metabolic? What medications are they taking? Could there be a vitamin deficiency? And especially in the United States, where bariatric surgery is done pretty frequently in certain communities, vitamin deficiencies from nutritional deficiencies in that setting are pretty common. And we've seen patients present with vitamin A deficiency, certainly very common, that often causes retinal problems as well as corneal changes, but also vitamin B12 or folate and absorption deficiencies. How about alcohol? I've had many patients over my career, including one just in the past year, who presented with really profound vision loss, and we were able to get some of it back when, in this case, she stopped drinking. I'm afraid that potentially during the stress of the coronavirus and job issues, I'm a little worried about her right now. Could it be inflammatory or infectious? And, you know, I always think about syphilis. We were told syphilis can do anything and look like anything. It's a little bit like sarcoidosis and tuberculosis as well. Could it be immune mediated? For example, a neuromyelitis optica patient that presents with optic atrophy long after they had the acute disease? Or could it be secondary, like a paraneoplastic process?
4% de los casos, ustedes saben que la incidencia del melanoma está.
What was that?
Yes, no, continue, sorry.
Okay, great. And, you know, always infiltrative ischemic and glaucoma, right? We see patients in neuro-ophthalmology with glaucoma. In terms of the history of present illness, really taking a careful history. What's the tempo? Is it sudden? Is it progressive? Is it bilateral or unilateral? Is the visual function stable? Did it improve? What are the associated symptoms? Pain on eye movement, headache, neurologic symptoms that are systemic, such as paresthesias. There's symptoms of giant cell neuritis, you know, jaw claudication, tongue claudication, new scalp pain, new neck pain, weakness, weight loss that's unexpected. And then you're not going to have to give them a laundry list of potential toxins that they were exposed to. When we think about a careful past medical history, I really want to know, did they ever have cancer? Were they ever diagnosed with cancer? How about infectious diseases such as HIV? What about autoimmune diseases? I've seen a number of patients with lupus that have a lupus-associated optic neuropathy, sarcoidosis, thyroid eye disease, toxic exposures. In particular, we always think about ethambutol, so widely used, and if it's used in you know, a high enough amount for a long enough time. Use of alcohol, and when I say real use of alcohol, what I've found over my career is you ask a patient, well, I'll give you an instructive. Years ago, I had a patient and I said, well, you know, do you drink? He says, yeah, I drink. I said, well, how much do you drink? He said, 1 a day. I said, well, one what? And it was 1/5 of scotch a day. So it was, you know, different. If I had said 1 a day and assumed it was 1 beer, that's a lot different than drinking a whole bottle of scotch a day. And then family history, which we've already talked about. In terms of visual function, sometimes optic atrophy is incidentally discovered. Someone looked in their eye, could be optometry, could be ophthalmology, and noticed optic atrophy. So you really want to know about visual function, not just what the optic disc looks like. And obviously we want to know the best corrected visual acuity, we want to know the color vision, we want to know the pupils for a relative afferent pupillary defect. And sometimes when you're worried about, is this, you know, optic nerve or retina, ERG and can be helpful, and OCT can be helpful. When I think about formal visual field testing, patients can come in with optic atrophy on one eye and bilateral visual field defect because of the underlying disease. So is there bilateral disease? And so you don't want to just concentrate on the eye with optic atrophy. With OCT, I want to look at the retinal nerve fiber layer, in part because the retinal fiber layer really helps us in compressive lesions identify, or at least give us some suggestion of whether or not that vision loss is reversible, whether they can recover if we remove that compression. And we like to do the ganglion cell analysis as well. So the question is, what else do we do? What do we image and when do we image them? And generally what we like to do is MRI the brain in orbits with gadolinium and fat suppression. And when should you have that done? It really depends on the tempo and the characteristics of the loss. Finally, is a normal report okay? Did the neuroradiologist read the study? As any neuro-ophthalmologist will tell you, we've seen many a quote unquote normal study that isn't, where for some reason the lesion was missed. Sometimes it's because we're not providing enough good quality information to the neuroradiologist to tell them where to look. What are our suspicions? You know, if we're worried about optic atrophy, we need to tell them we're worried about the orbit to the chiasm, if it's unilateral optic atrophy not affecting the other eye. On the other hand, if they have a junctional scotoma, we're going to tell them something's in that chiasm and we need your help. If it's a third nerve palsy, they're going to be looking for an aneurysm. So we need to really help our neuroradiologist. So other studies, well, chest x-ray if you suspect sarcoid, high resolution chest CT if you suspect sarcoid, other studies as dictated from the clinical evaluation. And finally, laboratories tests. What do I almost always, and I qualify that, almost always obtain? Well, I want to know their blood count with their differential. I definitely pretty much always want to know their SED rate and C-reactive protein because I don't want to miss an inflammatory cause that's treatable. I always check for syphilis in these patients. I might do an ANA. I might do B12 and folate. And then there's a whole laundry list of other things that I might do depending upon the history and examination. Sometimes a spinal tap is indicated and genetic testing is indicated, is done when it's indicated. When we think about things like pseudoatrophy, optic disc hypoplasia, we think about a small disc, bilateral in about 50 to 60%. You can see that yellow halo bordered by increased or decreased pigment in some of those patients. There's a tremendous amount of variability in severity, ranging from asymptomatic to profound decrease. Optic pits and colobomas or morning glory sometimes can be referred in as a patient having optic atrophy. These are congenital. They are very commonly, typically have visual field defects. And then the one thing to remember is that morning glory disc can also have this transsphenoidal basal encephalocele that you want to find out about. So let's go through cases, because I think cases are much more interesting than just hearing me ramble on. So this case, 56-year-old male referred for a diagnosis of retrobulbar optic neuritis. His past history was that he had noted decreased vision with a central scotoma about a week ago in the left eye. He had no pain with extraocular movements. He had no periorbital pain. On review of systems, he had no weight loss. He had no scalp tenderness. He had no headache, jaw claudication, or fever. His past ocular history was solely positive for a history of ocular migraine for scintillating scotomas. His past medical history is also significant for having had coronary artery disease. He had had a MI and stent. He had hypothyroidism, hypercholesterolemia, lots of underlying illnesses. But what makes it unusual about labeling this as a case of optic neuritis? So I would say there are a couple of things that tell us this is something weird. First of all, there's no pain with extraocular movements. So, oops, didn't want to go there yet. We know that patients with typical optic neuritis, more than 90% of them have pain. He's a little old for his new diagnosis of first-time retrobulbar optic neuritis. Can you get optic neuritis in your 50s or 60s or even 70s? Yes, but it's much more common in younger people. He's male. That doesn't rule out other types of optic neuritis, but typical demyelinating optic neuritis, you can have that in a male, but typically more commonly in a younger female. Although I will tell you, years ago, a very dear friend of mine came over on a weekend and said, Lynn, there's something funny with my eye. He was in his 50s. He had typical optic neuritis, subsequently was diagnosed with multiple sclerosis. So it can happen in any age group. But I would say that those are the red flags for me. He's not the typical gender, age for optic neuritis, and he has no pain in eye movements. And I'll show you that there's one other thing that just screams at you saying, this is not optic neuritis. So when we looked at him, his visual acuity was 20/25 in the right eye, 20/70 in the left eye, pinholing to 20/60. He had a relative afferent pupillary defect. His color vision was down. So it could be optic neuritis, maybe. When I looked at the back of his eye, I hope you can see that there's something different about this optic nerve. And it just is different than the other one. There's a little bit of paleness to this optic nerve. And because there has optic atrophy, you have to think, well, how long does it take to get optic atrophy? Even if you have a typical optic neuritis and you don't fully recover and you get some optic atrophy, it takes weeks to develop that. And this patient had a 1-week history of symptoms. So you already know this is not typical optic neuritis. So when we looked at the visual field, and I don't know whether we can make this interactive or not, Emily, but you'll let me know. When we look at this, huh?
No, nobody I'm making question. Probably in the final, and the final of the talk.
Okay, perfect. Okay, perfect. So this is his left eye, and he's got some diffuse abnormality in his visual field. You can see his fovea is down, but it's not down terribly. But what caught my eye should catch all of your eyes. What's going on here? So this would fall into a junctional scotoma, right? There is some defect in the temporal field of the right eye, and there's a generalized non-descriptive depression in the left eye. So it tells you something's going on in the chiasm. So it helps you to tell the radiologist to look at the chiasm. So what next? Now, this is the chiasm. This is not a normal chiasm, right? So this is a lesion that's sort of intrinsic to the chiasm. So not optic neuritis. That turned out actually to be a horrible diagnosis in this age group, and that was a chiasmal glioma. So chiasmal gliomas are not very common, and we're not going to have time to really talk about the different tumors of the optic nerve, but this patient ultimately lost his life secondary to this glioma that actually extended back into his hypothalamus. So next question, next patient. Too fast. 65-year-old male comes in and literally his complaint is, my vision is not good. He comes in with a complaint of a year of progressive vision loss in both eyes. He was diagnosed with a cataract, and he had his cataract surgery out in the right eye. He returns 3 weeks later. They look in the eye and they say, oh no, there's optic atrophy there. So then they do a visual field that was not done prior. Best corrected visual acuities were 2150 in one eye and 2100 in the other eye. So when you think about what causes bilateral, and it's sort of a secocentral type of visual field defect, you can see that here. One could say it's an enlarged blind spot going to the fovea, but I would describe this as an abnormal visual field bilaterally, but also there is a bitemporal type of component to it, and so I noticed something interesting when he came in to see me, sometimes at 10 o'clock in the morning. And what I noticed was that he had a very strong smell of alcohol. And he admitted to 2 to 3 servings of vodka per day. It wasn't a whole bottle, but it wasn't just a shot either. It was multiple shots 3 times a day. So does this patient need a genetic screen for Leber's hereditary optic neuropathy? Well, what's different about the presentation of this patient with a secocentral type of bilateral visual field defect? Well, go back, and you can have Leber's in older patients, and now that I'm not going to tell you my age, this is not old anymore to me. The issue here is there's a 1-year history of progressive vision loss bilaterally, and that's not the typical history for Leber's. You have another reason for this patient having what we used to call a toxic or nutritional optic neuropathy. In this case, it was a vitamin deficiency created by his alcohol overuse that led to his nutritional abnormality. And once we corrected his nutritional abnormality, the vision certainly fully came back in this left eye and mostly in the right eye. So how about another patient that comes in with a bilateral visual field defect and optic atrophy? This patient noted a loss of vision in his right eye about 3 weeks before loss of vision in the left eye. So it was sort of a sudden onset, and then 3 weeks later, another sudden onset. Best corrected visual acuity, 2200 each eye. So the tempo of the vision loss in this patient's much different than the case number 2, right? There was this sudden and then sudden, and you should start thinking Leber's hereditary optic neuropathy in this 20-year-old patient. So this is a picture of the fundus, and I hope that you can see this tremendous dropout of the maculopapular bundle. Tremendous dropout, and then the temporal atrophy that you see, which is characteristic in patients with this disease. And this was his visual field. Looks very similar to our patient with the toxic or nutritional visual field because it's that centrocecal pattern extending from the blind spot to the fixation or vice versa. He did have a family history for early visual field loss, and he does need genetic testing. He does need to be tested, and in fact, he did have Leber's hereditary optic neuropathy. So it becomes really important to listen to the patient and create your differential diagnosis based on how the patient presents as well as physical findings. Another patient, this is case number 4. Again, a 20-year-old male, and he had decreased visual acuity, comes in for another opinion. He had an optometric exam at age 8, and at that time, they couldn't correct him better than 20/40. Now he's 20/40 in the right eye, 20/60 in the left eye. His pupils are normal. He's got a mild decrease in color perception. Automated perimetry was fairly normal. It was really fairly unrevealing. Fluorescein angiography was unrevealing. He came to me with the MRI in his hand. I didn't have the opportunity to not get the MRI, and the MRI was normal. So when we think about this type of bilateral vision loss and optic atrophy, so bilateral vision loss, we think of macular disease. We don't get optic atrophy with that. But then when we do get optic atrophy, we need to think, could it be toxic optic neuropathy? Could it be a hereditary optic neuropathy? Could it be demyelinating disease with this as a sequelae? Or compression or infiltration of the nerves? So you sort of need to have all of those in the back of your mind. But with this history dating from age 8, and by the way, when you did his family history, his mom and uncles also have bilateral vision loss. This puts us into a different category of hereditary etiology, of autosomal dominant optic atrophy. So these patients typically will have an insidious childhood onset, a moderate decrease in acuity. They tend not to be 2200 or worse. They tend to be in this 2480, maybe a little bit worse. If you get color vision abnormalities, you really need to look carefully. You need to look for this blue-yellow dyschromatopsia. And again, you can get cecocentral scotomas in these patients. So let's go on, and case number 5. A 10-year-old boy comes in with progressive monocular loss of vision. Well, not only does he have optic atrophy, but I hope you can see that he has optic disc edema as well. It's not a great picture, but I think you can see that when you look at these blood vessels as they cross between the optic nerve and the retina, you sort of lose their distinction. You lose their distinction even on the optic nerve head. And for me, that's actually one of the best ways to sort of make me think, is this disc swollen? When you lose that, or when you get that vascular obscuration as you go from the disc to the retina. So this type of child with progressive monocular vision loss, optic atrophy, and edema, this is a patient you need to image, and you need to image them soon, like yesterday. So this patient had an optic nerve glioma, different from the 56-year-old that I showed you earlier. So gliomas in children tend to be a little bit different. Clinically, most of them happen before age 10, the majority before age 20, no sex predilection. This is another picture of a glioma. And when you examine them, proptosis is present in almost all of them. I did not tell you that when I showed you the picture of his optic disc, because I wanted you to think about optic atrophy. But this was that same patient, and he had profound proptosis as well, vision loss, optic disc pallor in about 60%, edema in about 1/3, and strabismus in about 1/4. Many of these patients come very late, and they won't be complaining of double vision because of poor vision in one eye. So let me go on and talk about slow progressive unilateral vision loss and optic atrophy. So this patient, the pictures are not of the patient was mine, but these pictures were from Novel, which is a great database to find very informative and illustrative pictures. 45-year-old woman with progressive unilateral vision loss over the past year. So already you're starting to think, well, this is getting worse. It's been about a year. So we really want to think more about her, and we really want to do neuroimaging. Now, it doesn't have to be done today because this has been progressive over the course of a year. So when we do neuroimaging of this type of problem, which is an optic nerve sheath meningioma, what you typically get is a diffuse tubular enlargement. You can see this as compared to the other optic nerve, this diffuse tubular enlargement. It involves the sheath typically. You get a relative sparing of the optic nerve substance. And so that's where they talk about the tram tracks. And I'm not going to be able to convince you that these really show tram tracking, because I think that doesn't really, these are not great pictures, but you get that tram tracking because you get the tumor itself is a meningioma, so it's of the coating around the optic nerve. Remember, it's got the pia arachnoid dura. Calcifications are common. They often, if they go towards bone, they can have hyperostosis of bone, and they're really well seen with enhancement with contrast, and that's what I'm showing you up here, because they tend to be iso-intense on T1 and T2 weighted images, but they enhance with gadolinium. This is case 7. Case 7 is a patient who just says, my vision is blurry. So this is an elderly patient with cataracts, glaucoma, hyperthyroidism. Best corrected vision is around 20/50 in the right eye, 2100 in the left eye, but she needs to look slightly down in the left eye to be able to see. She had mild optic atrophy noted in that left eye, and these are her visual fields. This is her imaging. So when I look at a patient like this, you could say, well, look at this visual field. It's primarily respecting the horizontal meridian. Maybe there's a little bit up there. Could this be a non-arteritic anterior ischemic optic neuropathy? We're going to talk a little bit about that later. But what I want to show you is that, this patient has thyroid disease. She's got hyperthyroidism. She's got lid retraction. And when I ask her to look up, her eyes barely move. And so you should have a fairly significant differential diagnosis. But one of them has to be compressive optic neuropathy, asymmetric, affecting one eye worse than the other. And I think I have these, I think I had some of this reversed, but at any rate, what you can see is that, oops, I went too quickly. So when you image her, this is mid-orbit. This isn't even in the orbital apex. And I'm sorry, I flipped the visual fields because this is her left eye, this is her right eye. And you can imagine that as you go more posteriorly to the back, to the real orbital apex, where that optic nerve is getting just squeezed by those large muscles. So this patient had compressive optic neuropathy from thyroid eye disease, and she underwent therapy and had dramatic improvement in her vision following therapy. Okay, this patient, her complaint is that she's bumping into doorways. And when you look at her, she's got optic atrophy. This is her visual field. So when you look at this visual field, you say, wow, she's bumping into doorways because she's got compression at the level of the chiasm. Again, you have a bitemporal visual field defect. There's a little bit more than bitemporal, but the gist of this is bitemporal. And you might want to go and you might want to then get an imaging study and see, what's there causing that bitemporal visual field defect. So let me show you her scan. And this is her scan. And she has an enormous tumor. And this is causing chiasmal compression, but causing a lot of other problems as well. And she needs to be evaluated by our neurosurgical colleagues really, with soon, because we want to see whether we can preserve or regain her vision. Okay. I'm going to show you another patient. This is a patient who basically said, my vision isn't right. 41-year-old, visual acuities 20/20 and 20/40. But when you look at her, she had a relative afferent pupillary defect and optic atrophy in the left eye. When we did a formal visual field, she had unilateral loss of vision that wasn't pathognomonic for anything. It was sort of diffuse. So what would you do next? Well, we certainly want to ask her some more questions, and I would say we still need a scan. So her past medical history was significant for hot flashes and amenorrhea. Her MRI is shown. This is her chiasm. This does not look like a normal chiasm, right? So the MRI, the formal read was the differential included the following: lymphoma, sarcoidosis, tuberculosis, hypophysitis, and on. So what do you do next? This, we knew there was going to be something there, but now what are we going to do to make another diagnosis? Well, her laboratory studies were unremarkable, but her chest CT showed hilar lymphadenopathy, and that was consistent with sarcoidosis. And ultimately, she was treated for sarcoidosis. Now, she presented with that dramatic visual field change that she actually recovered significantly. She did not recover fully, but she recovered significantly, and she recovered to 20/20 central visual acuity with still a little bit of a relative afferent pupillary defect, but not a very strong relative afferent pupillary defect. So another case, case 10, I woke up and could not see. So this is a patient, 79-year-old male, who complained of bilateral vision loss. And obviously, I think you can see that there's optic atrophy here. He had a history of chronic myelogenous leukemia. His white count was 44. And the hematologist note said, it's not his leukemia. His leukemia is not causing this acute loss of vision. His hemoglobin is okay. His platelet count is okay. His JAK2 status was negative, so he had a low thrombotic risk. So what do you do? What do you do? So we did an MRI, and the MRI showed that there was really prominent enhancement of the optic nerves bilaterally. Also enhancement of the chiasm and the tracts into the right mesial temporal lobe along the optic radiations. And it was really consistent with leptomeningeal carcinomatosis. And yet I will tell you, because this was a patient I took care of, it was almost impossible to get his hematology doctor to agree to do LPs and ultimately treat him. And this photo is actually from about a month after his vision loss. So what can we learn from this patient? I think we can learn from this patient that sometimes you need to be persistent in evaluating the patient. You need to consider all the possibilities. And sometimes the doctor that's been taking care of the patient isn't always the final stop for where you need to go to get additional opinions about what could be causing this. And so in his case, I received a lot of help from the neuroradiologist. Neuroradiologists have got to be your best friends along with neurosurgeons because and head and neck, because oftentimes we make diagnoses of patients that, I gave a talk to some graduating medical students yesterday, and I said, we're all taking care of patients in a fairly small geographic area, and we all have our area of expertise, and we need to be able to work all together to do the best for our patients, to take care of our patients in the best possible way. So sometimes having those relationships with your colleagues are really critical, both to getting patients in to be seen quickly, and also if you have multiple doctors taking care of complicated patients, sometimes it needs a few doctors talking in a group to discuss what the differential is and how best to take care of a patient. So now the last case I'm going to show you is going to be a longer case. So this is the longest case. This is case number 11. Case number 11 is a patient who came in saying, I'm pregnant and I'm losing my vision. I don't know about everybody who's on this call, but whenever anybody says that, I'm pregnant, am I losing my vision? My heart rate goes up, I start faster, because I know we need to make some tough decisions, both about evaluation and management. So she's 36, she's 16 weeks pregnant. She has 4 sons. This is a patient we took care of just in the fall of 2019. All of her prior pregnancies were absolutely normal. She is obese, significantly obese. So when you walk into a room like that What are you thinking? What's the differential diagnosis? What are your goals for this patient? What questions would you ask, and what are the critical parts of the examination for this patient? And before we go on to the examination, you know, I think it's totally reasonable to get that history. I'm going to give you a little bit more history in a few minutes. You knew that that was coming. But when I'm thinking about a pregnant, obese patient, the first thing that will come to my mind is, you know, does she have idiopathic intracranial hypertension and secondary loss of vision from that? But this is an optic atrophy talk, so you know that that's not going to be it. But that would be the first thing that came to mind. So let's go a little bit further. So this is her examination. She's 20/20 in the right eye, 20/40 in the left eye. Pinhole, no improvement. Ishiharas are great. Her color vision is fine. She does have a 1+ relative afferent pupillary defect, a little bit of a cortical cataract. Her motility is normal. And her fundus has trace temporal pallor. Well, that didn't help you much, did it? Didn't help you much. So what do you do now? Well, I always like visual fields. You know that. I always like visual fields. So this is her visual field. So number one, you could say, well, great. You know, the right eye is good. The right eye is fine. It looks absolutely normal. But when we look at the left eye, we see, oh, the foveal threshold is down. That's consistent with having optic neuropathy and her 1+ relative afferent pupillary defect. And she has a lot of vision loss. Her mean deviation's -20. And does this help you with the differential diagnosis? We're going to get into that in a moment. I'm going to also show you her retinal ganglion cell layer on OCT. So when we looked at the ganglion cell layer using a macular cube, you know, my heart starts dropping a little bit more because, wow, she's got significant thinning in her average ganglion cell IPL thickness, both minimum and maximum. And this is very different than the other side. And so now I'm sweating a little bit. So this is not the retinal nerve fiber layer that helps predict recovery. This is the ganglion cell layer. And I'm going to show you later that that doesn't always correlate with what the patient sees and tells you. So we'll talk about that later. So this is really profound loss, and yet she had a 1+ relative afferent pupillary defect, 20/40 vision. So you start thinking, you know, wow, could this be something reversible here? And so, you know, what's the differential diagnosis now? Well, I will tell you a little bit more of the history, which I didn't give you before, sort of on purpose, because I want you to think these through with me. The patient was evaluated in a different clinic, not ours, and given a diagnosis of non-arteritic anterior ischemic optic neuropathy. She was sent to her obstetrician gynecologist for evaluation of a possible hypercoagulable syndrome. So what do you think about NA-AION as a diagnosis? What doesn't fit here? So I'm going to go back a couple slides. So the first thing, and I'm going to tell you this so strongly, you may not ever make a firm diagnosis of NA-AION unless you see the patient when the optic disc was swollen. You should not make it on a patient with pallor, with atrophy. You could say, possibly, you could say, I suspected that this patient had NA-AION, but you cannot make that diagnosis. What else is funny about NA-AION? I don't see patients with a cup-to-disc ratio of 0.5 getting NA-AION. NA-AION is a disease where you have a small cup-to-disc ratio. It's in a crowded small optic nerve. So 2 strikes against NA-AION as a diagnosis. The visual field, well, okay, yeah, there's some respect for this horizontal meridian. It's really dense below. there's more than that. Can you get a visual field that looks like this with NA-AION? Absolutely, you can get a visual field that looks like this. But you may not make the diagnosis solely because the visual field has an altitudinal style defect. So I'm going to digress for a moment. A few years ago, a friend of mine who's a surgeon calls me up and says, you know, Lynn, my father-in-law, who is a retired doctor, 80 years old or 85 years old, was just diagnosed with NA-AION. Would you see him? And I said, I'm happy to see him because I'm happy to see any patient, but you know, does he really want to come in and have this whole evaluation? Because if it's NA-AION, I'm not going to really, you know, I'm not, other than looking for sleep apnea, making sure they don't have that and treat it. I'm not going to have a specific diagnosis. I'm not going to have a specific treatment plan other than modifying what's modifiable risk factors from a systemic standpoint. And he said, no, Lynn, I just want you to come and, I just want him to come in and see you. It'll make me feel better. I actually should have put that case into this slide deck because I would have loved to have shown you the photo. Dilated the patient. He had a small cup to disc ratio in the fellow eye. He had an altitudinal visual field defect. But when I dilated him and looked in his fundus, he had a branch retinal artery occlusion causing an altitudinal visual field defect. He did not have NA-AION, but he did have something we needed to treat, right? We needed to treat that medically. So altitudinal visual field defect does not tell you that it's NA-AION. You have a differential diagnosis that includes glaucoma. Okay, I'll continue. Oops. Okay. So I don't think it's NA-AION. Could it be optic neuritis? Doesn't really sound like optic neuritis. Could it be compressive or infiltrative? Yeah, it could be that. So let's think about something a little bit more. I already told you about that other case. So maybe I did. No, I did not put his put that patient's thing. So we already talked a little bit about NA-AION, where you have to have the swollen disc and the altitudinal. You don't have to have the altitudinal visual field defect. You should have some visual field defect. Clinical presentation in those patients is abrupt loss of vision, not progressive loss of vision, and you need optic disc edema. The small cup to disc ratio in the other eye is disc at risk. You can have some pain in NA-AION, so don't dismiss NA-AION as a diagnosis in a patient who otherwise fits and has some dull ache for the first week or two. Most common visual field defect is inferior, altitudinal. Systemic risk factors, as we all know, is hypertension, diabetes, hypotension acutely, uremia, dialysis, or sleep apnea. And we really want to treat the modifiable risk factors. Okay, we know about NA-AION. In NA-AION, we don't need neuroradiology or spinal tap. We might, and most of us would do, a SED-rate and C-reactive protein to rule out giant cell arteritis. And the clinical course is that we really do have some patients will improve, some patients will get worse, and the risk of the fellow eye is somewhere around 15%. We can argue whether it's 10 or 15. Recurrent AION is rare in the same eye, but risk of the fellow eye. And then treatment for sleep apnea. So what about optic neuritis? Could it be optic neuritis? Well, the typical optic neuritis presentation is going to be subacute, days to weeks with, in terms of onset of vision loss. Typically, it is a young patient in this age group, typically female. Pain's a hallmark, as we talked about earlier, in about 92%. Pain can precede the vision loss, but can last for days, and it does not correlate with visual outcome or clinical course. Visual acuity can range from just about anything, and about 90% will recover. As we talked about earlier, optic atrophy happens late, doesn't happen early. You can have optic disc edema in about a third. For patients with optic neuritis, we want to do MRI of the brain in orbit of all patients. And the reason for that is we want to know, is it typical in terms of the neuroimaging? Does it look like a typical demyelinating type of optic neuritis in terms of the optic nerve itself? Are there other lesions that tell us that the patient has a very high possibility of developing MS? And if there's only one brain lesion present at the initial time of optic neuritis diagnosis, the 15-year risk is a little bit more than 70%. So we want to do neuroimaging for patients with optic neuritis. But now we know that we also want to look for things like NMO, neuromyelitis spectrum disease, or MOG-associated disease. And then when it's atypical optic neuritis, there's a whole lot of other things that one can think about. Optic neuritis would be a whole lecture by itself, but just to highlight a couple of features that when you're thinking about NMO, spectrum disorder, or MOG, we really want to look at orbit, brain, and spinal cord, because the brain abnormalities can change over time. And spinal cord abnormalities, especially in NMO spectrum disease, span 3 or more contiguous vertebral segments, and that can help you make that diagnosis. The same thing for MOG. In MOG, we think optic disc edema is more common and that it's more common to be bilateral and recurrent. Okay, and then just to hone in some of the differences of neuroimaging for these diseases. MS optic neuritis, you can see some gadolinium enhancement of the optic nerve, a little lesion here that's consistent with typical demyelinating optic neuritis, aquaporin 4 or neuromyelitis optica spectrum associated optic neuritis, typically a long segment of optic nerve involvement, and it can be bilateral. And then a patient with MOG. The neuroimaging will not tell you the diagnosis. It'll just be one more piece of evidence as you're making a diagnosis. And then for the way I think about evaluation for patients who I think have optic neuritis, I want to know, you know, do they have aquaporin 4, MOG, MS, or other? Because it changes the treatment that I'm going to want to give them. And many times you're not going to get the, you're not going to be able to get the NMO testing or MOG testing in time to make those treatment decisions. So you have to follow these patients quickly or over time. And I'm not going to spend more time because I'm sure in this series you're having a whole session on all of the ins and outs and nuances of caring for patients with typical or atypical optic neuritis. So back to our patient. She decided to get a second opinion with UCLA. Actually, her neurosurgeon asked for a second opinion. So now you know that she did see a neurosurgeon. She had gone to it, she had had an MRI. It wasn't with contrast because of her pregnancy. They noted the abnormality, but felt that the abnormality was not the cause for vision loss in this patient. Her neurosurgeon wanted a second opinion. I'm going to show you the MRI. So this is a sagittal view of the MRI, and you can make out that there's something here that shouldn't be here. And here you can see this. So this is a meningioma. And it was told to her that she had a small meningioma. And just another picture. And it was recommended that they consider surgery after she delivered her baby. So then you have to think, but she says that she's getting worse. She's losing her vision during the pregnancy. Her neurosurgeon was the one who actually requested the second opinion. And she brought in her MRI. I wanted to review the MRI because I thought that that meningioma looked like it was involving the canal. And I wanted the neuroradiologist, again, to help me understand whether it could be impacting or impinging on the optic nerve, causing her progressive vision loss, in which case I was going to recommend surgery in this pregnant patient who's obese. So I was sweating a lot. I was very anxious about this patient. So I said, come back in 2 weeks, because she told me she's losing her vision, but I don't have any evidence that she's losing her vision. And at that point, I didn't have her prior records because she felt awkward about asking for them. So she came back 2 weeks later. Her visual acuity was still 20/40, but now she's losing her color vision and she's got a bigger relative afferent pupillary defect. So now I felt like she had a decision to make. And I will tell you that the type of decision making took a few hours of my time with her husband, with the neurosurgeon, because it's a tough decision to undergo neurosurgery during your pregnancy, especially for a tumor that's involving the canal, because we know that surgery in that region could make her vision better, could make her vision worse, right? If you don't decompress that optic nerve, but you have some complication at the time of surgery, you could have a problem with your vision. You could have a problem with your life. You could have a problem with the pregnancy. So a really, really, really tough decision. But ultimately, she decided to undergo her surgery. She underwent a bifrontal craniotomy, tumor resection, and the surgeon felt that it was complete tumor resection. Now, I saw her again over time, and she wound up coming back 5 months later for all of her evaluations. And at this time, we did retinal nerve fiber layer, which you can see is down in the left eye. But it is above 70. It's close. I can't read the number here, but it's above 70. And so when we think about patients with compressive optic neuropathies, below 70, it gets to be a little bit dicey to think about recovery. Some people can, but how was her vision 5 months later? Now she came in bringing her baby, and her vision fully recovered despite loss of retinal nerve fiber layer. She had no relative afferent pupillary defect. Slit lamp exam was unchanged. Fundus showed a little bit of optic atrophy consistent with this loss of retinal nerve fiber layer. This was her visual field. Remember her pre-op visual field? So in fact, this patient was a compressive optic neuropathy. So what does this tell us? Well, remember her horrible retinal ganglion cell layer earlier? So retinal ganglion cell measurements, that one that I showed you earlier in her case discussion, doesn't always correlate with vision and return of visual function. Number two, you can't diagnose NA-AION in a patient with optic atrophy unless they were evaluated during the onset and you saw optic disc edema. And finally, patients can recover good vision in compressive optic neuropathy. And I will tell you, as a 36-year-old woman with now 5 children, she was so very grateful. And remember, it could have gone a different way. So, I called her neurosurgery happened during the American Academy of Ophthalmology meeting this year. And I called the neurosurgeon during the meeting because I wanted to know how the surgery went and how she was post-op. But ultimately, I think this is a real save. For the rest of her life, she will have good vision. So what are the take-home messages when I've given you sort of a fast tour of lots of patients that had optic atrophy in association with vision loss? Is that really one size does not fit all, and I don't have a full checklist of all the things one needs to think about or ask as you're encountering the patient. but I would start with that history. Is it unilateral or bilateral? What's the visual field? What does the retinal nerve fiber layer look like? What's the ganglion cell analysis look like on OCT? What are the associated signs or symptoms that can help direct you to doing a targeted evaluation? What's the past medical history or a family history of vision loss? If so, learn the details. Determine the next steps based on all of the possible information, and you'll define a targeted and appropriate evaluation that will lead to the diagnosis. I want to thank you so much. This is Stein Eye Institute. So this was the very first building. We have 3 buildings. This is the Jules Stein building. This is the Doris Stein building. That was the second one. And then this is the Wasserman building. The whole building does not belong to ophthalmology, but there's operating rooms in the basement, and then several floors that do belong to ophthalmology. And here's the School of Medicine. And I spend my time rotating between about this office in the School of Medicine and about this office in the Stein Institute. And I want to thank you. I'm going to stop screen sharing and look forward to a discussion.
Thank you so much. It's wonderful talk. Thank you so much. It's wonderful. I think you have too many congratulations here. And also you have a question. I think that Roberto Ebner want to do a question. Roberto?
Hi, Emily. Thanks for the opportunity. Thank you, Lynn. The lecture was terrific. And I have one question on your last 11th case, which is very interesting. You made the point, but I would like to go back to that point, which is OCT. You live by the rule, when you find some ganglion cell defect, this is forever. And you mentioned that in your case, you recovered the visual field defect. How do you explain that having this OCT, which is perfectly seen, the ganglion cell defect, you recovered? That's my question.
You know, I would love to, the first time, I have seen this more than once. And it puzzles me as well, because I have seen this. Oh, thank you so much. I'm so grateful to all of you. I have seen this in other patients, and one thing that I would love to do is collect a series of patients in whom I've seen this, and I haven't done it yet. So I invite everybody, look for those patients where you see the ganglion cell analysis on OCT and a disconnect between that huge red area and the recovery of vision. I've seen it several times. Tony Arnold has seen it several times. I think it's time for us to look for those cases, put them together, and then try to figure it out. I think it just tells us that thinning, because that tells us the thickness, right, of the retinal ganglion cell layer with the inner plexiform layer. So thickness does not always correlate with function. And so I think we need to probably start looking very carefully with some enhanced OCT mechanisms to try to understand more when we see that in the setting of patients who then recover visual function. She does have optic neuropathy, right? She still has an optic neuropathy. She has optic atrophy, but her function, her function was better. I think it's a mystery. I would love your hypothesis.
Okay.
No, I've been looking for your next paper on that.
Okay.
Let's put it together.
Thank you, Robert. You have another question. Excellent conference, Dr. Gordon.
Thank you.
Sometimes the neurosurgery had patients with pseudotumor cerebri, and in a few cases, optic atrophy may be visible. How could you differentiate an optic atrophy of a chronic pseudotumor cerebri from an optic atrophy of another etiology?
Yeah, I think that's particularly hard. We see optic atrophy even in patients with swelling of the optic disc, right? So, and we know that once you've lost enough fibers, you're not necessarily going to get swelling.
Mhm.
So, so I think in some cases that can be incredibly challenging, especially in patients with pseudotumor cerebri. If early on in vision loss with pseudotumor cerebri, they often have a visual field defect that looks a lot like glaucoma. They often have, you know, this peripheral arcuate defects like you have in glaucoma. But late on, you can actually, you know, we all have seen, unfortunately, you can wipe out the visual field. So I think that you need to, I think that we've had a recent patient of Laura Bonelli has had a recent patient where there was a similar issue. However, in that case, the patient's visual function got better after the pressure was lowered. And so you have to look at the patient in the same way. I think you do the visual fields, you have to do the nerve fiber layer evaluation. Sometimes they'll look atrophic, but they're still going to be swelling. So you can still see some swelling. What do you think, Emily?
Well, I think in order to make the difference, as she asked about optic atrophy, I think in intracranial hypertension, the fundus of the eye, almost of the visual field as you explained, I see the fundus of the eye of the patient with optic atrophy for papilledema, they has more glial reaction.
Yeah.
It has more, they look a little different to the other, and the pattern of the visual field loss is different, it's more general.
Yeah, I think you're right. There was a question about blue-yellow dyschromatopsia.
Yes.
You know, I think doing a 100 hue test or really very formal, detailed color vision test for me is the way that I like to do that, because many of the other little tests that we do or the small tests don't really differentiate that as well. But
You had another question in Spanish. Let me translate. It says, in case of optic atrophy, what treatment do you use? What do you think about the stem cells?
Oh,
Water?
I'm hopeful that at some point we will have stem cell therapy.
Okay.
We don't right now.
Okay.
I have not seen evidence for stem cell therapy working. I'm really hopeful that we will. But remember, so if you're trying to replace retinal ganglion cells, if in order to get therapy to work or optic nerve regeneration to work, you know, you have to have the cells, you have to get the axons, and those axons that start off in the eye need to go all the way to the lateral geniculate, right? And there are lots of people working on optic nerve regeneration, and there's a lot of good evidence for different steps. And my hope is that in my lifetime, I will see regeneration or stem cell therapy that works. But there's a long way, both metaphorically in terms of experiments, but also physically in getting from the eye to the brain.
Okay. Okay, let me check if we have another question here. I don't know if you can see the chat.
I can see the chat now. Now that I'm not sharing,
wonderful.
I couldn't before.
Thank you, Gordon. Can I make a question about the second case? Yes, Marco, you can do it. Marco, si quieres tomar el micrófono, si quieres hacerla.
Hola.
Marco.
Hola.
First, I want to congratulate you for this wonderful chat. It was beautiful, really beautiful. And I usually dedicate my clinic to glaucoma. So when I see this, I really enjoy it. I mean, the way you think and the way you presented it. And the good thing is that you remind us that we usually spend more time in requests for an organ to the patient. And that is something that we have to remember now. And the other thing is that not every scotoma is glaucoma or is a retinal lesion. They can mimic one another, but that is the truth. Now, I had a question about I think it was the second case where you had a centrocecal scotoma in the gray pattern, I think, in the gray scale. And, but in the pattern deviation, it was a bitemporal scotoma. It wasn't an hemianopsia.
Right.
So usually, in glaucoma, when we're talking about glaucoma, we don't give much importance to the grayscale.
Right.
And in this case, it was the difference. It was really the difference. So how can you explain that? I mean, you have a bitemporal scotoma in the patterns deviation, and you have a grayscale with a centrocecal, very clear centrocecal scotoma. I mean,
yeah. So first of all, as a neuro-ophthalmologist, what I always tell my students not to look at the grayscale. But in this case, it really worked out. But the most of the time I say ignore the grayscale. So it's great that you picked up on that. So what I tend to do, usually, I can't explain that particular case, except he just was so far, I mean, he had just lost a lot of optic nerve function at that point.
I can't remember the final diagnosis. Was it a toxic?
I think wasn't that the one was alcoholic?
That one, yeah.
Yeah, I think it was the alcoholic, and that was the most extensive loss that I've seen from nutritional. What I tell people is to look at the pattern deviation, but for my glaucoma colleagues and neuro-ophthalmology, I say look at pattern and total, because remember, the pattern allows us to change sort of the floor, what's normal, to account for people with diffuse loss from cataract, for example, or some diffuse depression, right? And so sometimes that actually can hide neuro-ophthalmic causes of visual field loss. So I've seen some patients where the pattern deviation is normal, but the total deviation is diffusely depressed from their neuro-ophthalmic optic neuropathy. Okay. So what I tell our residents, because a lot of our residents really just look, not just, but primarily concentrate on pattern, is that you have to look at both, and then you have to look at the numbers. I like to see the numbers.
That's true. That's true. Because what I thought is that maybe it implies that it doesn't mean there is the rest of the sensibility was not reduced, but it wasn't reduced enough to have an effect on the grayscale. It's still in the normal values. Yeah. But when you compare to the rest of the numbers of the sensibility of the retina, that is why it appears on the pattern deviation. I mean, even though maybe if you let it go, I mean, in time, it will decrease. It will also affect the grayscale. Maybe, I don't know.
Yeah, good, very good point. As I said, any one of you could have given this talk because you're all so smart.
No, I don't think so.
I do.
You have another question. Who are doing the best research in neuroregeneration at that moment?
Yeah. I think there's a lot of places that are doing really excellent work on neuroregeneration. I think it sort of depends on where in the pathway. So there's a person by the name of, it's Grakowski. I have to think about the name at USC, who is doing a lot of experimental work on, that's very interesting. She presented her work at Nanos. There's also a lot going on at Stanford, Stanford University. The chair of the department has done a lot with trying to look at that. There's a number of different sites, but those are the first two that come to mind.
Okay, thank you. Well, I see we don't have more questions. You have a lot. Congratulations here. Many thank you. Great talk.
It's great to see you. I miss you.
Miss
And
you
And I just want everybody to stay healthy, for their families to stay healthy, and to see you hopefully at some future Pan American conference or the American Academy of Ophthalmology or NANOS.
Thank you, doctor. Thank you for teaching us.
Thank you, doctor.
Thank
you
you.
so much.
Thank you.
Okay. Be
Okay.
well.
See you soon. Bye.
Bye.
Bye. Gracias a todos y a la doctora por acompañarnos. Fue un honor tenerla hoy acá con nosotros. La otra semana les estaré enviando el link para las próximas presentaciones. Hasta luego.
Bye.
Bye.